Great. Good morning, good afternoon, and good evening, everybody. Thank you very much for joining us today for this webinar, Nutrition Information During the COVID-19 Pandemic, Guidance and Experiences from the Field. So before we get going, my name is Ben Allen, and I am the Deputy Program Director of the Tech RRT. We have a number of presenters on the line today who I will introduce shortly. Some of you have already started doing it, but if you haven't, if you could introduce yourselves in the chat box, that would be most helpful so that everyone else knows who is on the line. And also, please keep your videos and videos off and microphones on mute, and just the presenters will be showing their videos today. Please, and as you may have heard me just say, this webinar will be recorded so that anybody not on the line today will be able to view that later on. So I am first going to just acknowledge those people and organizations involved in the webinar today. First, excuse me. First, we have the GTAM. I'm sure many of the Global Technical Assistance Mechanism for Nutrition. I have no doubt that many of you already know what this is, but for those who don't, I will just give a few words on what it is. So it's a global mechanism endorsed by over 40 global nutrition cluster partners to provide systematic, predictable, timely, and coordinated nutrition technical assistance in order to meet the nutrition rights and needs of people affected by emergencies. So there are various aspects to this, but one aspect is there are a number of global technical working groups who are dedicated to specific technical areas, one of those being the Nutrition Information Systems, GTWG. And that group, some partners in that group have had an instrumental role in putting this webinar together today. And they are Action Against Hunger. We have from Alexandra from the UK and Hassan from Canada. They will speak very shortly. And also UNICEF, we're very lucky to have Louise, who will be presenting for us shortly. And on top of that, Mathieu and Lucy. Again, we'll hear from them shortly. And the Technical Rapid Response Team, we are facilitating and putting on this webinar today, alongside a number of other webinars in the COVID Nutrition webinar series. And as I mentioned already, the Global Nutrition Cluster, particularly Victoria, the Nutrition Information Help Desk, has been involved in putting this webinar and the subsequent ones in English, in French, Spanish, and Arabic together. And finally, the SMART team, housed by Action Against Hunger Canada, has also contributed. So a quick, next slide, please. A quick acknowledgement of some donors who support our work and have made this webinar possible today. And next slide, please, Alexa. So what are the objectives of the webinar today? They are fourfold. Firstly, to give an overview of current nutrition information system recommendations in the COVID-19 context. Secondly, to present some country-level experiences of using existing systems and innovative techniques to collect data, and particularly looking at how these can be utilized or adapted to the new challenges presented by the COVID pandemic. And thirdly, we're going to look at a review of nutrition information system innovations that are available and again could be utilized to help us deal with the new challenges that have been presented. And we will do our best to keep to time, as will the presenters, so that we can preserve a good half an hour at the end for question and answers from the participants. And on that note, if throughout any of the presentations you have a question, you have a comment, or even you have any experiences or ideas that you want to share in relation to any aspect of today's presentations, please go ahead and put it in the chat box. And then those will be filtered and reviewed and collected and addressed during the Q&A session. So yes, as I said, please input there at any point during the presentation. Okay, next slide, please. So the agenda, very quickly, adheres to some of those objectives that I outlined. So objectives and introductions. We're going to have some introductions from all the presenters straight away after this next slide. We're then going to have a presentation on the nutrition management surveillance and monitoring in the context of COVID-19 brief from Louise from UNICEF. And we're then going to hear a case study from Zimbabwe, from Mathieu, a case study from Kenya, from Lucy, and then Alexandra is going to present those NIS innovations that I mentioned before. And finally, lots of people are dealing with different technical challenges at the moment. And so I'm going to give a very brief overview, reminder on how practitioners can request technical support to deal with nutrition-related challenges. And then we'll have a Q&A. And then at the end, I will ask you all to very kindly fill out the webinar evaluation. At some point, I can even do it now. I have put the LRL into the chat box, URL, sorry. And if you're able to complete that at the end of the webinar, that would be much appreciated to help us make these webinars better for you all. Okay, next slide, please. So I'm going to hand over to the presenters now to introduce themselves. I've already done myself. So Louise.
Hello, everybody. My name is Louise Mirigi. I'm a nutrition specialist focusing on information and data. I work for UNICEF and I am based in the nutrition section in New York headquarters. And also a co-chair of the Global Technical Mechanism, the Nutrition Information Working Group. Yeah.
Great, thank you very much, Louise. And we also, from UNICEF Kenya, we have Lucy.
Greetings to you all. This is Lucy Maina Gatigi. I'm a nutrition officer, information systems with the Kenya country office. I'm an embedded staff in the Ministry of Health, Kenya. Thanks.
Great, thank you, Lucy. Welcome. Mathieu.
Yes, good afternoon, good morning to everyone. I'm Mathieu. I'm the nutrition manager for UNICEF Zimbabwe. I've been there for a year and a half. Before that, I was in Mozambique and Kenya, actually, and Somalia.
Great.
Thank you.
Thanks for joining us, Mathieu. And Alexandra.
Hi, everyone. Another French accent. So I'm Alexandra Ruti-Sauzer Pereira. I'm the head of nutrition for Action Against Hunger in the UK. And I'm also the co-chair, like Louise and Hassan, of the GTAM on nutrition information. And funnily enough, before being based in the UK, I was actually based in Kenya.
Great. Thanks for joining us, Alexandra. I can see lots of things connecting all the presenters together here. Hassan.
Hi, everybody. My name is Hassan. I'm the Senior Project Manager for the SMART Initiative based here in Toronto. I am also the co-chair of the Global Thematic Working Group for Nutrition Information Systems, and I am originally from Kenya.
Great. Thanks for joining us, Hassan. Okay, without further ado, we're going to move on to the first presentation from Louise. So if the presenters could turn their videos off. And Louise, take it away.
Okay, so thank you everyone for joining the webinar. I'm just going to provide a brief overview on the brief that went out. And just to say that the brief that we provided initially does provide some broad recommendations on nutrition information management and monitoring in the context of COVID. As we continue to, as we move forward on this, these briefs will be updated with new evidence and more practical solutions. So this was the beginning and the first one, but we hope to update them as we move forward. Next slide, please. So it was becoming clear to us that obviously there was a need for us to continue monitoring the nutrition situation as we do for our programs regularly, but also now taking into account the COVID-19 pandemic, which also has put in place some measures for preventing the spread. And some of those were directly impacting how we collect information in the field. And so we thought that it would be necessary for us to have a common understanding and provide some broad recommendations on what to do in terms of data collection, analysis, and monitoring given the current situation. We do hope as we move forward to document and disseminate some of the lessons learned, and also, like I mentioned earlier, be updating this information as it becomes available. But right now, we have some broad recommendations that we would want to share with you all. Next slide, please. So in terms of, for those who've not seen the brief, I think I hope you've seen it, but we'll provide a brief overview now of what has been recommended in terms of data collection activities. While we recognize the risk of COVID-19 being transmitted through data collection, we also realize that we do need to be able to continue collecting information. And so based on this and based on the recommendations that have come out, which really call for physical distancing, we have then asked that we avoid, we have broadly recommended that we avoid, which is in line with the guidance that has been shared, and we limit interaction between people. And therefore, we are saying that we should avoid all data collection activities that involve in-person interaction. And this includes mass screenings, household visits, population-based surveys, and so on. We would then need to use alternative ways of data collection. And so we are advising that it will be easier to adapt what we already have. So it's important for us to map out what we have existing in our countries, look at what existing digital platforms are there, what data systems are already in place. And then once we have taken stock, it's easier for us to be able to explore the potential of using these existing systems to collect the data that we require. This would be one of the key points that we would encourage countries to do. And this would even involve looking at some aspects that would make this practically possible. So for example, looking at issues like even connectivity, mobile phone connectivity, and even internet connectivity. It's important that we do this exercise with government and with partners, and first, and also identify what information needs that we need to be collecting, and which ones can be collected remotely. So for example, if we talk about data collection through mobile phones or calls or text messages or web-based surveys, it's important for us to also be clear on what information we would want to be collecting. And this needs to be done, obviously, considering the data that we usually collect for our population groups, and then also identify if there are other vulnerable population groups that we may need to focus on. Once we are clear on this, I think it will also be good to, in those discussions, to initiate efforts to be able to train and build the capacity of enumerators or those who would be involved in any kind of remote data collection. they will be, or rather in country, we're sure that there is different partners and agencies that would want to take this forward. And I think if we go to the next slide, which if we go to the, yes, thank you. So the next slide really emphasizes the importance of coordination. It is important that we ensure that we have in country a coordination body, whether it's a nutrition information working group that exists or any other related coordination mechanism in place to ensure that all stakeholders, agencies are coordinated on matters related to nutrition information systems. And this is important so that we can leverage on existing systems and resources, whether it is actual funding to conduct the activities, the human capacity, or the actual systems itself, so that at this time we can avoid duplication of efforts. There will be obviously a great need for information, so we just want to make sure that even as we all try to make attempts to collect information, that we need to ensure we're doing this in a coordinated way. We would also within our sector need to be coordinated, but this is a time also that we would also need to be clear how we are coordinating with other sectors. So for example, the food security sector, the health sector, the WASH sector, social protection, and so on, because they are also collecting information. And in some ways, some of the information or systems that they're using to collect the information can be utilized by us, including also some of the indicators that they're collecting, which will be useful for us to be able to do a full analysis. So coordination within the sector and also coordination with other sectors is also important. If within, as part of coordination, there are also other existing, like either nutrition working groups or health working groups, for example, the disease surveillance working group. It's important that we're also connected with those working groups to be able to ensure that we are also able to use information that comes from them, or if there are systems that we can use there to leverage some of the information that we would need to collect on nutrition. I think it would be important that even through this group, develop a work plan which is very clear on what data needs to be collected during this period, what the analysis plan is, and also what and also on aspects of reporting. Yes. Can you hear me?
Yes, you just have to repeat what you just said again. You did go away.
Oh, okay. Where did I go away from? On coordination, right from the beginning?
No, just the last 10 seconds or so.
Okay, so I was just saying that through the Nutrition Information Working Group, or whichever coordination mechanism will be instituted in the country for nutrition information systems, it's important that through that group that you develop a work plan which is going to address data collection, analysis, and reporting issues. And this should be based obviously on the existing M&E framework in the country. So this way, everyone will be able to access what the plan of what data is being collected, analyzed, and used for nutrition in the country. What the other key point that we wanted to say is that this is the time also that we need to maximize utilization of existing data and information systems and make this information more readily available. So next slide, please. We need to ensure that we are using what's already existing. This can be useful for us to understand the situation, the nutrition situation pre the pandemic. Using also that information, we'll be able to understand the delivery of our nutrition programs. If we have a good understanding of the nutritional status of the population and existence and performance of the programs, then it allows us to be able to build and prioritize the data gaps that we will need moving forward in terms of the context, in line with the context of COVID. So it is really important for us to be able to look at pulse surveys, coverage surveys, facility-based surveys, look at sentinel site information, and also make this information readily available and use this information, for example, for trends analysis. This information will also be useful for us to do situation analysis and also triangulation with other relevant sectors as needed. The other point is that we should be able to, where possible, now that if we have established that we can collect some of this data from existing sentinel sites, for example, that we should then use those existing sites, maybe with modified methods. So for example, phones or web-based surveys, we can leverage the existing data collection points that we have. And once again, here we would need to ensure that we have done prioritization so that we're only collecting the best data possible through these means, but also the information that's critical for our nutrition programming and response. And it's to this point we say establishing new indicators are neither easy, as we understand, as we know, and will be a bit difficult to interpret. So we should only establish these indicators if needed. And so at this point, we really need to be careful. And I think we need to be guided, like I said earlier, on the two key points, being very clear what it is and prioritizing what we need to use, and really build on existing data and information. In terms of the frequency of reporting, I think this is also a key point that we need to consider. In some instances, there may be need for a higher frequency of data collection and reporting based on the situation and needs. And in others, we may even see that we may have, we may not reduce the frequency of reporting on certain indicators. And so it's important that also as we think about the indicators that we would want to collect and the methods and so on, that we also put the frequency of the data collection in mind, and we adjust it accordingly, also to meet even the reporting requirements that will be established by the stakeholders. Lastly, data should be made easily available to all stakeholders. This is very important because often you may find that you want to collect something that's already existing somewhere, but has been either for some reason or not, is not easily accessible. So this is the time that we feel it's very important that at country level, we make all information that's important easily accessible to all stakeholders. And this will also avoid discussions or duplicating efforts in data collection and help us to leverage existing resources. Next slide, please. So speaking specifically to the potential adaptation, so to how we are going to be collecting data in the context of COVID-19. So we have two scenarios where we have no population movement restrictions and where we have either partial or full restrictions being enforced. So for routine systems, so this would be like HMIS or other data that's collected on a routine system, where we have no population restrictions, we encourage that we continue to support HMIS to collect the data, and this would be either providing training or remotely or through virtual means, supporting additional capacity for data reporting at facility level if this is possible, and really just ensuring that we are supporting, we're investing in supporting the additional capacity for us to be able to improve the data quality of the system. Again, ensuring data sharing and its utilization. So this could be done either through having access to the different systems online, having dashboards where colleagues can view reports, and not just for HMIS, but also, for example, if they're early warning systems or sentinel site data, it will be important that this data is made available. And then if there are changes or adaptations, it's important to share these different guidance with countries and all these additional resources on conducting secondary data analysis, and also guidance on how data from these sources can be utilized. Where we have partial restrictions to make the adaptations for the routine systems, we encourage the monitoring and tracking of nutrition service delivery. And so this would be, for example, using innovative approaches. So for example, mobile technology to be able to look at the service delivery of key nutrition programs. It's important for us to also identify certain indicators that have been collected systematically over a period of time. These indicators can be used as proxy indicators to monitor disruption of nutrition services. So, for example, looking at a trend analysis of certain indicators that are collected routinely over time and seeing what would be expected, and then from there being able to use that as a proxy to see if the results that one is getting are because of disruption of services. And then lastly, in terms of routine information, would be to continue obviously to support these systems where possible. And like I said, some would be using other different remote systems. So for example, either mobile data phone collections or web-based surveys. Next slide, which will now focus on adaptations.
Sorry to interrupt you, Louise. You've got 1 more minute, please.
Okay, yes, this is actually the last slide. Okay, so when it comes to surveys, for the surveys, we're actually advising, like I mentioned earlier, that we suspend all household population-based surveys. This is in line with the government directives which will be in place in countries, and also to curb the spread of the disease. Where we have no population mobility restrictions, we're also saying this would be a good time to start initiating discussions on use of innovative ways to collect data and increase the capacity in country to analyze and use secondary data. Where we have partial or full restrictions, again, we're still suspending and using the same as above, looking at different options and exploring other non-touch assessments. Next slide, please. So in terms of the next steps, like I said, this is the first set of recommendations. We want to start looking at more practical and innovative approaches, working with countries so that we can be able to share these more widely. We would also want to hear from countries so that we can identify specific priority areas for support on nutrition information related activities. We are also working on consolidating a list of indicators that can be used to inform nutrition and data needs during this pandemic. And then also, these will be disseminated widely so that they can provide some guidance. There will also be circulation of updated guidance. So for example, what will come out from the cluster in May on nutrition humanitarian needs analysis guidance, and also the IPC, which will be developing some assumptions in the context of COVID. Yes, so I will stop there. And
thank you very much. That's okay. Thank you very much, Louise. That was a very comprehensive overview of the brief. Those of you who have not seen the brief yet, somebody kindly posted the link in the chat box. We'll also share that resource along with other resources once the webinar is over. If everyone could, as I mentioned at the beginning, those who just joined wouldn't have heard, please do put your questions, reactions, ideas into the chat box, and they will be collected and addressed during the Q&A session. So let's move on quickly to our first of two case studies. So we've heard a very detailed overview of the brief, and now we're going to hear from two examples of where adaptations have or are ongoing in regards to nutrition information management. So over to you, Lucy.
Okay, thank you. I'll be taking you through the country case study for Kenya. And to let you know of the situation in Kenya, we have, as of 28th April, we have 374 confirmed cases. 124 have recovered. Unfortunately, we have lost 14 people. Next. My outline is I'm going to take you through planning standards, guidelines, and tools, coordination of nutrition information, physical distancing and alternative data collection methods in the context of COVID, utilization of existing data and information, and next step. Next. In terms of strategic planning standards, guidelines, and tools, just to put things into perspective, we have the Kenya National Nutrition Action Plan 2018-2022, which includes key resort areas on emergency and nutrition information strengthening, and is accompanied by a nutrition monitoring and evaluation framework. We operate through nutrition programs, and across this we have technical working groups. And one of the key technical working groups is the Nutrition Information Technical Working Group. To be able to effectively coordinate the COVID-19 response, we have a core team to coordinate these activities. And so far, we have been able to develop a guidance on continuity of nutrition services in the context of COVID-19. And at a subnational level or at the county level, we also have county nutrition action plans and county nutrition technical forums, which are actually the mechanisms where nutrition in COVID is also being discussed and linking to other sectoral and multi-sectoral groups at the county level. And just to highlight that we have had a functional pre-crisis nutrition information system in Kenya. And therefore, this has given us an advantage when we come to the nutrition information management for COVID. And within the preparedness and response plan, we have been able to include a nutrition information system and the required process level indicators to monitor implementation of the plan. Also, we have adjusted our 2019-2020 annual work plan to include COVID, NIS, and MNE. And we have actually guided counties to ensure that during their planning, they include costs related to IPC in terms of the surveillance costs. We are in the process of adapting the global guidance on interim monitoring and evaluation. And we are also reviewing our Kenya early warning system for continued surveillance. And here we are leveraging on the early warning system ICT infrastructure, because there we already have monitors who have tablets and are at the community level. Next. Next. In terms of coordination of the nutrition information system, we have an existing nutrition information technical working group with a clear TOR. And therefore, during this period, we have been able to continue coordinating activities from that level, and we are holding virtual meetings. And we have a small group or core group that is constantly following up on key actions. And at this NITWG, we are working with stakeholders to address arising information needs, to review opportunities, and also think around the innovative approaches that are required for data collection during this period. We are also providing technical oversight while looking at the different areas that are already available from the regional and global level. And through this, we are able also to maintain standards and also to exchange information as we are doing today through this webinar. The Nutrition Information Technical Working Group is also participating in existing multi-sectoral and sectoral forums. We are providing regular updates to our Emergency Nutrition Advisory Group. We are participating in the Data and Information Subcommittee of the Kenya Food Security Steering Group. And this is actually where a lot of the information around the early warning is being discussed and the adjustment thereof. We are also getting engaged in other COVID-19 coordination mechanisms within the Ministry of Health as well as other sectors. And we have increased frequency of meetings during this period to be able to serve the different needs that are arising. At the county level, we are having participation of the nutrition sector, our government counterparts at the county level, our partners are participating in the coordination mechanisms, like for example, the COVID-19 coordination mechanisms that are mainly being convened by the health sector, as well as at the more senior administration point, that is the governor level. Next. In terms of the alternative data collection methods and capacity strengthening, in order to sustain the physical distancing, we have emphasized the adherence to the Ministry of Health IPC guidance, as we are developing all our guidance, including the one for monitoring and surveillance. We have also adjusted our data procedures and are actually discouraging any individual interaction data collection procedures or suspending even some. For example, we have mass screening and population-based surveys suspended. Growth monitoring and promotion and the associated data collection is only being encouraged during the scheduled immunization. We are encouraging non-touch methods such as the use of family MWAC and use of standing weighing scales instead of the baby scales and such. And UNICEF is currently supporting procurement of family MWAC as well as the PPEs to cover gaps that are there because the supplies have been inadequate, like many other countries. We are using online platforms, including emails, to facilitate review and validation of data. For example, we were in the middle of reviewing and validating our smart surveys for February and early March, and that we have concluded through online meetings, also for program performance review. And the working from home modality for partners as well as some of our government counterparts is allowing us to continue desk level activities and deliverables. Also to highlight, we have been able to hold meetings and actually sensitization of our 47 counties across the country have been sensitized on the interim nutrition guidance, the business continuity plan, as well as the preparedness and response plan, which all include the nutrition information system through virtual means. But what we have actually realized is that we actually need to be very intentional in supporting our government counterparts on the funding for virtual meetings, that is airtime and bundles. Next.
Lucy, just to let you know, you have 2 more minutes.
Okay, in terms of the existing systems, we are using data from the pre-crisis period. For example, the caseload calculated during the IPC for acute malnutrition done in February. We are using our information from the DHIS2, our early warning system, as the main data sources. We are also exploring and expanding existing systems such as the FuseNet to collect food prices in additional areas, realizing this is nutrition sensitive information. And our early warning system is being adjusted to collect data remotely. We have shortened the questionnaires. We've been able to cost the new modality, and we are discussing family MWAC as MWAC measurements have been suspended. We are developing a comprehensive list which will be available to counties, and also adjusting our imam surge approach in COVID-19 to analyze data within the catchment facilities. We have increased the frequency of situation reports and updates, and we are uploading nutrition information products in our country websites. That's the Ministry of Health and the nutrition website. Next. In terms of next steps, we are finalizing the interim guidance and indicators. We'll be piloting our reviewed early warning system and then scale up. We will be sensitizing the teams on revised early warning system. And then continue reviewing our imam surge approach and the digital platforms that are available so that we are able to use them at the national and county levels. And we are in continuous discussion with our stakeholders such as the Community Health Department, the National Drought Management Authority, and the Kenya Red Cross to be able to identify and utilize available opportunities to collect nutrition data from communities, households, and also from caregivers. Here we are actually thinking about Rapid Pro. Thank you.
Great. Thank you very much, Lucy. Very interesting overview of what you guys in Kenya are doing in response to the COVID situation. I'm now going to hand over to Mathieu from UNICEF in Zimbabwe. But before I do that, just another reminder to everyone, as lots of you are already doing, please put your thoughts, questions, ideas, and suggestions into the chat box, and we will address those during the Q&A session at the end. Mathieu, over to you.
Thanks, Ben. Hi, everybody. So I will cover in a very, very short, hopefully, presentation our initiative in Zimbabwe on the use of Rapid Pro in this context of what was initially a drought emergency humanitarian response for us, but then now got even more acute because of the COVID-19 impact of the COVID-19. Next slide, please. Or maybe I can pass it myself. But yeah, okay, good. So maybe most of you, I'm sure, are relatively familiar with what a Rapid Pro is about, but let me cover quickly on the details of that. So Rapid Pro, it's kind of an open source software. That means it can be used by anyone that allow communication of data using some type of rapid SMSs. So that's one thing, and maybe one of the key feature here is you don't need to have a smartphone, you don't need to have access to internet or data bundle. You just use a normal basic phone and with the SMS function, and that will do. So it's been used here to actually communicate data from frontline health workers, both village health workers and facility-based workers on a set of indicators, which I will present later on. Rapid Pro presents a second advantage, which is the possibility of a reverse billing solution system. That means the cost of the SMS, the cost of sending the SMS to the database is can be charged on UNICEF in this instance, or on the one that carry the solution. So what you just need is to develop with the service provider a short code that allow the village health worker or the nurse to send SMS to, and he will not incur any cost on his personal phone. It will be charged on the service provider. So that's quite useful, knowing that usually cost is a barrier for many of our health workers in a constrained environment like Zimbabwe. Next. Okay, so this is really the core of what I wanted to present to the groups today. Let's first go on the right side of the slide, which is about sorry, I'm shifting here. Okay, which is about the data flow. So what we are doing right now with the Rapid Pro is actually not to replace any of the routine information system like the DHIS2 that we have in country, but instead is to fasten a bit that or get that that communication, that data flow, I would say, sorry, that data flow going a bit faster to the national level. And to do so, basically what we're asking VHL workers and facility nurses is to send data, information directly to the national level. Here is the Ministry of Health, that is the recipient of the data at national level, the M&E department under the sorry, the nutrition department. So they're the one that collecting it directly. And indeed, we bypass the district and the provincial level that usually take quite a lot of time to compile information, analyze, clean up, and so on. So that system allows us actually to, instead of having to wait about a month or so or to get data to the national level for use, we get it within a couple of days, so which is quite useful. Now, one of the trade-offs is, of course, we get raw data. We get data that are not necessarily cleaned and validated by the subnational level, the district and the provinces. So what we do instead is, when it goes to the national level, we quickly review the data, and then we have a kind of feedback loop to the provincial and the district level for their kind of further validation in case we have red flags. So this is how we work on the system here, and it's really much using the same indicators with the same case definition and the same templates, reporting templates that are normally used in the DHIS2. So we didn't come with new indicators. So talking of indicators, what are those indicators? We've selected, in the context of Zimbabwe, 9 high frequency indicators. Right now, some of them will be reported on bi-weekly basis, twice a month. But in last year, when we piloted the Rapid Pro, we did it on a weekly basis for the cyclone response, because we felt that was the right frequency. So don't get stuck into how frequent it needs to be. It's really based on your need. And the 9 high frequency indicators we selected are just listed on the left of your slide. And they are mainly to do with SAM and MAM treatment, vitamin A, MNPs, IYCF messages, and RUTF. RUTF being selected as an indicator because we are facing continuous challenges with in-country logistics for our RUTF supply and availability at health facility. So we selected that one. Again, this is definitely should not be prescriptive. I will recommend that you define your high frequency indicator you want to monitor based on your context. For us, we considered 3 things. The first one was indicators that give us information about on the trend. We know that in the COVID context, things are fast moving. We are seeing hotspots of malnutrition that we didn't expect before. So we want to really monitor trend on a very regular basis. So SAM and MAM admission in health facilities is one of the proxy, knowing that like Kenya, we do not have any more community-based screening activities going on. So we felt that was an important one. Vitamin A, MNPs, it's very much linked with some of our monitoring and accountability to some of our core commitment and humanitarian response commitment that we have put in our plans and in our donor reporting as well. And as I said, our UTF is because we've not been very good at maintaining a supply chain constantly operational. Another piece of advice here around selection of indicators will be do not get carried away with trying to put too many indicators, especially for Rapid Pro. If you're using the SMS function of Rapid Pro, it's become very cumbersome for health workers to start entering more than 5 to 10 indicators. Last year, we went ballistic with over 20 indicators at a point, and the more indicators you put, the less quality and the less amount of reports you're getting. So do not, I will recommend, at least on Zimbabwe experience, do not go beyond 10 indicators on high frequency. And usually, in fact, you don't need that many indicators. Good, next slide. Yes, okay, so before you move on into setting up a real-time reporting system like the Rapid Pro that we are using here in Zimbabwe, what do you need to consider? If you're starting from scratch, it's probably going to take you, depending on the context, obviously, but between, I would say, 1 to 2 months possibly to set it up, given that you already have some expertise in country, like you have an ICT department or a T4D, a technology for development specialist, or kind of backup that can help you around the ICT side of it. It's not a very complex technology, but it needs to be set up in a correct way. And it takes about probably 1 to 2 months to set it up from scratch. For us, we ride on the pilot that we did last year already. So we knew exactly what were our shortfall last year, what we needed to do better for this iteration, and it still took us about a month. So what do you need to consider before starting? First, and it's kind of echo a bit what Louise had mentioned in her first presentation, you have to map existing information system in country. These tech-based digital systems for rapid reporting is becoming really fancy and very fashionable. It's not very new, but over the last few years. So it's very possible that you have in some countries already some technology being developed, hopefully through the government or through the Ministry of Health, or maybe before through NGOs, that is already being proof tested. So I will recommend that first you map very quickly any type of system that could already real time or could be tweaked a bit to become real time. I'm thinking about DHIS2, eDHIS2, so the digital version of DHIS. Sometimes you have the outbreak surveillance system that is a digital platform that can be upgraded to include nutrition. So really don't rush into a solution before you have identified what is existing and what of course are your need. Secondly, you have also, of course, to map the whole indicators and data flow to really understand where you want to plug your system, your real-time system, and where you don't want to plug it and leave the system operate by itself. What I'm trying to say here is, for us, we really identified that the bottleneck for rapid reporting was from the frontline workers, so being the nurses and the village health workers, to the district level. That was usually the communication flow was paper-based. There was this step of validation that was taking time. So we said this is the one that we need to shortcut for the time being. But we didn't want to bypass all the systems. So really identify your indicators, identify where the bottleneck in your regular system is, and this is what you need to improve, not the entire system. So don't start from scratch and don't try to address everything in the system that is already in place. The third one.
Sorry to interrupt you. You've got 2 more minutes.
Sure. The next one is, as I've already alluded, is use a shortcut. So use a single kind of phone number, a short one that everybody can remember and can use. It's preferable that, of course, you have existing contract with service providers, mobile network operators, and so that you don't have to go through that iteration of negotiation with the mobile network operators to do so. Okay, I will skip a couple of things. Those slides will be shared anyway, so you will be able to read and reach out to us in case of additional information. But maybe the last one I wanted to talk about, yes, RapidPro doesn't allow you to do visualization or type of analysis. So you will need to have a solution that works at the back of the RapidPro to be able to generate data analysis and visualization, because RapidPro will not do that. RapidPro will just give you a long list of numbers in an Excel sheet that you can export in Excel, but will not allow you to do some type of analysis. So you need to work on some technology. For us in Zimbabwe, we are using ONA platform, which allows analysis and spatial visualization, of our information. I think that's my next slide anyway. Next. Oh yeah, key lesson learn. Okay. Yeah, I think I've mentioned that before. Look at existing system, don't start from scratch. Include the RapidPro process into the activity plan that you anticipated. And more importantly, is engage with your Ministry of Health, mainly for us. And in the Ministry of Health, it gets a bit complex. So don't engage only with nutrition, engage also with their DHIS unit, their MNE and planning colleagues as well, so that they are all on board. Otherwise, what will happen is at a later stage, you will get probably a pushback from some of the departments that felt should have been involved before. This is relatively time consuming, but do that upfront before you have to do, otherwise you will have to do damage control. And I think that's pretty much it. Yes.
Great. Wonderful. Thank you very much, Mathieu. So a pretty detailed overview of the RapidPro surveillance system in Zimbabwe. Mathieu, you received a number of different questions on specific details, so be ready to answer those in the Q&A. And please do continue to put your questions in the chat box. We've got a lot so far, so thank you very much to those already. And without further ado, Alexandra.
Hi, thanks a lot, everyone, and thanks, Mathieu, for your presentations. That is a good, I think, transition to what I wanted to present. So, just wanted to give a little bit of brief history of this tool, which was initially supposed to be a very internal Action Against Hunger tool. So I'm sharing a group within Action Against Hunger called the Nutrition Information Think Tank. I know it sounds very nerdy. And we really felt when we were talking together that we couldn't really make sense of all the things that were existing. There were so many things out there. We needed to have something. We needed to have a tool that could briefly explain for each of us what were all those innovations that were all there before we can even decide which one we would like to use and which one is more adapted to every context. So once again, this tool was supposed to be very internal. I worked on it with 2 of our interns. And then a few weeks ago, Hassan contacted me because he participated to a webinar. He knew that this thing was a draft in my to-do list for a while, and mentioned that due to the situation with COVID-19, actually, we needed to finalize this document and get it disseminated. So it suddenly got onto the top of my to-do list, and that's why we shared this document a few weeks ago with the international community. And on the chat box, Ben just shared the link with you to the document. Next, Alexa. So one thing that was really important for us as well, again, trying to make sense of all of it, is the fact that when you look at any types of information system, not only nutrition, you have to really view it as a cycle. And for nutrition information, we call it as a AAA cycle, where first you need to assess a situation, and very often it can be done with routine data generation, and timely reporting, which is really, really important. And that's where innovations can bring a lot of help. Then once you have those data that you've assessed, analyzing them, that's the second A, and doing the interpretation of those data. And then obviously the third A is about action and taking decision and making decision on data, and making decisions that are with individuals, but also the collective. Next, Alexa. So based on that and based on this AAA, we also thought that in this review, and I really want to insist that this is only a review of tools. So we reviewed a certain number of tools. You can click on the next animation, Alexa. And basically this list that you see on the screen is the list of all the tools that we've looked at. And for all of those tools, we've also determined if they were linked to data collection or data analysis or dissemination, because if you want to be able to have action, and especially collective actions, you need to disseminate those tools. And we divided them in 3 categories: the ones that are very nutrition and health specific. And you can see a few of them. I'm not gonna read them all, but FuseNet, for example, is on the list. ENA is on the list. The state of acute malnutrition, which is a great source of dissemination of information, is on the list as well. There's a question about what is a SAM photodiagnostic app. Well, have a look at the review and you'll have your answer. So that's the first category. The second category is on mobile health or mHealth, and that's where the SAM photodiagnostic app is listed. And finally, we thought it was also important to have some other information tools that are not necessarily specific to nutrition, but are quite often used in nutrition or could be used in nutrition. And I think Kobo, for example, will speak to many of you. It's not specific to nutrition, but is used a lot when we do assessments. Basically, this review is about looking at all of those tools one by one, looking at the fact that if they are involved into data collection or data analysis or dissemination. And then next slide, Alexa. Next slide. Next slide is only an example. No, the one before. Yeah. So do not read these slides. It's just a print screen that I took basically from the review for you to see what you can find inside. So because Hassan was on this call and that the Smart Plus is Hassan's baby, I decided to take Smart Plus as an example for presenting you with this tool. But basically all the innovations that are mentioned in the previous slide, so all the ones that were listed, follow the same structure. So for all of them, we explain what the tool is, how it works, the use of the tool, and what this tool brings to nutrition information. And for a lot of them, you have a link to a website, or for some of them, you even have a link to a specific person that you can contact if you want to have more information. So I just wanted to warn you also about this tool and not raise your expectation too high either. It's called a review for a good reason. This tool will not tell you which innovation you should use or which innovation would be the best for your context. This is something that we leave up to the people developing a nutrition program. It's really only aiming at explaining what those innovations are. Also, the methodology to do this review was only to do basically a gray literature review. So we went through the websites, we went through documents, but for most of them, we didn't go and interview the people who were developing the innovations. So that's also a limitation of this version. Once again, I remind you that initially this tool was supposed to be an internal tool to help people within Action Against Hunger, but then we decided to open it to everyone. And so, for example, so this review is not perfect. And we can make it a lot better, and we would like to make it a lot better in a new version. So next slide, Alexa. So we hope that this will already help you to try to make sense of all that is out there. But once again, we think a new version that could come up before the end of the year would make it a lot stronger. So for example, Mathieu, Rapid Pro is not mentioned in the review. And I think with what you explained today, I didn't know about it. I think I'll be in touch with you because it's definitely something that we could be included in the new version. So basically, if you're on this call and your tool is mentioned, and you think that maybe it's not mentioned completely accurately, or you would like to have it updated, please contact us, and my email is on that slide to tell me that you want it to be updated in a new version. And if your tool is not mentioned, contact me so that we can add it to the next version, following the same structure that I showed you in the example. So yeah, have a look at it. It's basically a catalog, and we hope that it will help you make sense of all that is out there. Thank you very much.
Wonderful. Thank you very much, Alexandra. During that presentation, I shared the link to the document. So participants, please feel free to go and access that on the Knowledge Against Hunger website. I also pasted Alexandra's email address in there if you didn't catch it. So thank you, Alexandra, for that overview of that a very important piece of work from Action Against Hunger UK, and thanks for making it available to everyone. So before we move on to the Q&A, so you've heard from Louise describing the nutrition information in COVID context brief. You've heard from Lucy and Mathieu, two very interesting case studies of work going ahead in Kenya and Zimbabwe to adapt their nutrition information processes to the COVID context. And you've heard from Alexandra about some other approaches that are out there that might assist you in your nutrition information challenges in the COVID context. But maybe you don't know where to get that support, and you need that support. Luckily, the GTAM, and part of that, the Tech RRT, exists to support you. So on the slide now, you can see 3 different types of support that you might need and the listed providers. So if you want remote, as most technical support is at the moment, you want to hire a consultant, or if you want quick technical advice on on nutrition information or any other nutrition and emergency thematic area, then you can seek it. Go to the Nutrition Cluster website, and you will notice the new Global Nutrition Cluster website, and you will notice that there is a big button saying Request Help, and that is where you fill out your technical advice need, and then you will be contacted. So feel free to do that at your leisure. So let's go on to the Q&A very quickly. We have 20 minutes left. So if I can kindly ask all the presenters to come back, and by that I mean with your videos, And I'm going to hand over to Hassan, who has been studiously watching the chat box and is going to lead us through the Q&A session. Hassan.
Thank you very much, Ben. I'm very happy to see a lot of you being very active on the chat box, and there's quite a number of questions. Just to note that in the interest of time, if we are not able to address all the questions, we'll still be providing a written summary of all the questions and possibly all the responses that are needed. And that hopefully will be shared as and together with the other materials from the webinar. So jumping into the questions, we have a few questions that we received prior to this webinar, and I'll start with those ones. This one, I will address it to Louise. And this, a colleague is asking, what are the nutrition indicators we should consider, and how can we collect information remotely where there's no internet facilities?
Thanks, Hassan. So we're currently in the process of compiling a list of indicators that we think will be useful for countries to consider in the context of COVID. And so that will be circulated soon. But in general, what I would want to advise countries is what I talked about earlier, is that we would need to start first and foremost work off our existing monitoring framework for nutrition within the countries. What are the existing information that we need to collect for nutrition programs in our country? And then once we understand that, what are the critical gaps? And I think it's very important that even as we consider new indicators, and this is why we were saying we need to think about them very carefully, is that we are in a situation where it's going to be extremely difficult to collect nutrition data the way we usually do. So for these additional indicators that we want to collect, there's going to be a need for us to invest in different methods. So either remotely or maybe through a different system, which will obviously mean that there's some engagement in that. There's also some capacity that needs to be built. So even as we think about the indicators that we need, I think we should really be clear why we need to collect that information, what it will be reporting on, and where that information will be used. So we will provide a general list of what we propose, but I think the key message here is that as we think about these indicators and the complexity of sometimes even collecting them in a normal situation, as we think of new indicators and collecting them in a more complex scenario, we really need to be clear on what the information is going to be used for in the context of that particular country and what it will help to support. I hope that answers the question.
Thank you very much, Louise. While I still have you, Louise, I'll just go ahead with the follow-up question. And a colleague was asking, as we are seeing more and more institutional visits or visits to health facilities decreasing, how important is data or HMIS data during the lockdown situation, and how reliable is this data at this point?
So yes, that's true. It's not reliable. And this is why I think it was very critical when we talked about ensuring that you understand the systems that have collected information in your country in the past, and you actually do a situation analysis to determine where you were pre-COVID. There are certain indicators that you know, for example, have been collected consistently over time. So for example, we could say like SAM admissions. So you know that, for example, if that's the context of your country, that's collected over time, it's in the system, and you're able to make decisions using that data, understanding even its limitations and so on. So for example, such an indicator, when you understand where you need to be, then you could say, for example, at this time of the year, facilities would usually report X admissions, and we understand which facilities maybe would not be reporting and so on. So once you understand the context, and then you're now in a situation, for example, where either countries are not able to report, or maybe the program has stopped, or maybe they don't have enough supplies, you would be able to see that through the trends of information that you're getting. So in a way, we would have to, I say in quotes, use proxies to be able to do some of this analysis and make decisions. And then maybe that's when you can, based on information that you get from that, maybe start considering other ways of collecting information. So maybe it will just have to be qualitative information that you would collect, calling those specific health facilities which have been affected and so on. So I think what's important is those key kind of broad considerations that we had in mind, and bringing it back to really what the needs are and what needs to be to be monitored, and then prioritizing those gaps. And to keep in mind that, you know, it's true, the same health facilities are usually overstretched in normal times. So we can expect a dip in reporting. And if we were actually then asked, what is it that we would want to even be reporting from these facilities? I think we need to be able to answer that. And that comes only from understanding the system before, understanding what you need to collect, understanding the critical gaps, and then making those prioritizations. So this is why we're saying, even when we talk about new indicators, let's have this process where we've really understood that. We've discussed with partners and stakeholders internally. Maybe there are other methods or other sectors that can be collecting information that's useful to us. So this is why we really want to emphasize the issue of coordination and the issue of using what's existing and leveraging of that to be able to find practical solutions for each context. Over.
Thank you very much, Louise. A colleague was also asking more a confirmation question on, regardless of the approach of data collection, whether we're using survey data collection teams or remote teams in the field, the recommendation is that we should not be collecting anthropometric data. Is that right?
Well, for us to collect anthropometry data, it means that there has to be that in-person interaction with the children and the mother and so on. And so this is what, in line with the guidance that's coming on limiting the spread of COVID, that's difficult to do. So yes, we're saying then any surveys which involves in-person interaction and enumerator moving from place to place, or people coming together, we're saying then that we should avoid and discourage. And yes, that would include anthropometry. There have been discussions on using the family MOAC, for example, but again, it would need to be done in a way that also the mother then is able to take that measurement because she lives with the child. And if we're using it for surveillance, then that measurement needs then to find a way in which it can be sent up so that we can use the actual measurement. So I know it's being used for detecting which kids need treatment, but if we want to use it for surveillance, then it means that somehow we would need to be able to collect all these measurements or status of the children if we're going to use it for surveillance. Over.
Great, thank you very much, Liz. A follow-up question, I don't know if Douglas is on the call, but this is an IPC question. And the question is, now that this is a period for conducting, many countries are planning or looking at conducting IPC analysis. There is a talk around virtual IPCs, and the colleague is asking if there are positions, the position of the group or the IPC group on how these virtual IPCs would be conducted, and if there are any special considerations that need to be taken. I don't know if Douglas.
Hi everyone, this is Douglas from IPC. Yes, our guidance on IPC analysis during the COVID-19 pandemic is in line with the GTAM guidance on information management. So we are not promoting, or we are not asking countries to go out and collect new data, but we are providing assistance on how we can use the existing data to analyze the situation, taking into account the impact of COVID-19. So we have different scenarios in different countries. Some countries have just collected data just before the lockdown started in their countries. So in those countries, we are looking at that data and then applying the problems associated or that came after the COVID-19 lockdowns. For example, immunizations have been stopped, and screening have been stopped, and etc., etc. So how it might have impacted on nutrition situation, and what is the outlook might be now. So that's one scenario. And the second scenario is where countries have implemented IPC acute malnutrition analysis before the COVID-19 pandemic. We also did some projections as to how the situation might be in the next 3 months or next 6 months. So in those countries, if the projection is still valid, we are updating the projections based on the current situation, like data from the health information system or food security mobile data, or any other data that we can collect during the pandemic. We use that data to see how the situation might have changed, the projections have changed, and what could be the current outlook. So that's another scenario. The third scenario is that where we have historical data, we look at the historical data and then also look at the current context and current data. And between these two, we project what would be, or what could be the possible scenario in the next 2 months, next 3 months, taking into account the level of lockdown, whether the epidemic has reached in the peak in the country, whether is it mainly urban area or rural area. So looking at all these situations, then we do the IPC projections and updates. Over.
Thank you very much, Douglas, for that comprehensive response.
Hassan, I'm sorry to interrupt you.
Yes.
We've had a lot of questions already, and they can still keep coming if there are other ones. But because of that, we are going to go over the scheduled time by 10 minutes. So we're 5 minutes before the scheduled end, so an additional 10 minutes in order to touch upon lots of your questions that have been coming in. Thank you, Hassan.
Thank you. So this is more a question to Lucy, and some of the colleagues were asking, what kind of data are you collecting from the early warning systems? And what data elements were added to the early warning systems in Kenya?
Okay, thanks, Hassan. In our early warning system, we have multi-sectoral information being collected. And here we look at selected wash indicators like distances, trekking distances for animals, water availability for domestic use. We also have information on food consumption score, coping strategy index, terms of trade, the status of pasture and browse, MWAC, which as I said during the presentation has been suspended for now, milk and milk availability, and many more indicators and that we are collecting that are multi-sectoral in nature. Thanks.
Thank you very much, Lucy. And the follow-up question was, were you able to collect data from all the health facilities in Kenya?
From our district health information system, we have the system across the country, and we are using it for all the 47 counties, and it is collating data from both government institution and faith-based facilities, as well as also private facilities, but the coverage of that is not as great as the former two. Thanks.
Thank you very much, Lucy. Now moving to an area that has shown a lot of interest, the Rapid Pro, the presentation from Matthew. And the first question is Rapid Pro directly sending information to DHIS2?
So right now, no, it doesn't. It's a function that we wanted to do, but when we wanted to look back that to the DHIS2, that meant we needed to have systems to have data validation that is slightly outside of what the DHIS will do. So if you want to start entering data from the top at national level, you need to have ensured that province and districts have validated that. So that got a bit complicated. So right now it's not, but it's completely possible to have that done. Over.
Thank you. And a follow-up question is, are there any ways in Zimbabwe, in the context of Zimbabwe, to collect data from those without access to phones? And how did you do training and capacity building for such target groups?
Okay, so getting reports from people that do not have phone right now, no, it's not possible. Now, because most of the village health workers, which is really our lowest cadres, most of the village health workers are paid through online kind of M-Pesa type of system. They all have mobile phones. So we didn't see that as a bottleneck, but it could be in some countries, a bottleneck. So no, we don't have, we have not considered that that type of reporting for people that do not have mobile phone. Over.
Thank you. And just following on that, you mentioned that this was a bottleneck. Like, what were some of the other challenges that you found during your piloting or during the launch of this system?
Okay, well, I've mentioned a few of them already. It's to be too ambitious with your system and trying to put too many indicators. This is one of them. One of the complex things is as well registering every health workers and village health workers with a single number. It sounds simple, but it gets very complex. Some of the numbers are not functional, SIM cards are lost, and new numbers are put in. So maintaining that database is quite complex. In terms of capacity building, because I forgot to respond to that in your previous question. So because of the COVID, when we had started the training before the COVID, but because of the COVID, we had developed online training package, and that was very simple because it's all mobile phone based. People can actually test the system directly by themselves remotely without much complication. So actually, you don't necessarily need a face-to-face kind of training for this type of thing. It's relatively simple. Most of our village health workers and health workers are familiar with those indicators because they are not new to them. They are indicators that they report through the paper-based system. So it was just to get them used and familiar with the SMS. And what you can do is you just send them live the SMS queries, and then they fill it, and then you can see directly real time the numbers coming into your database. So that can be very interactive, and that can be done remotely very easily. So that's actually a very strong added value here. Over.
Thank you very much, Matthew. And maybe a final question, more confirmation. A colleague was asking if the Rapid Pro system is collecting both qualitative and quantitative data.
So for us right now, what we use that system for is only quantitative data and mainly and only supply side data, right? So we didn't go into checking patient-rated outcomes, satisfactions and so on. However, what we have designed on the side, and that could be a topic for another discussion another time, what we have designed on the side is using what we call U-Report, which is basically Rapid Pro. We have about 120,000 people out there in the communities that are U-Reporters, and we are sending them pools, we are sending them questions about, are you aware about that service? Have you accessed that service? How was it? And so on. So again, don't try to overload the Rapid Pro with too many things and trying to measure too many dimensions, but we have also put on the side another system to monitor more the demand and the qualitative side of the program.
Thank you very much, Matthew. A final question from the list of questions, and this is more a cluster related to the cluster. And a colleague is asking, how can we provide evidence to the nutrition cluster when to start emergency nutrition response?
I guess that's not for me, is it?
Yeah, no, it's maybe to Victoria or Yara if they're on the call.
Hi, Hassan, this is Victoria. Can you repeat one more time the question, please? Sorry.
The colleague is asking, how can we provide evidence to the nutrition cluster on when to start the emergency nutrition response during this period?
Right, that's a loaded question. I believe most countries right now are already scaling up their preparedness measures, and even if they're not reaching kind of high levels of cases in their countries, we are advising countries to already start implementing their preparedness plans and making sure things are starting in terms of coordination, whether it's with regards to this topic of nutrition information or in terms of their programming. So if there's specific questions at country level, don't hesitate to get in touch through the link that Ben shared earlier on the Nutrition Cluster website, and we can discuss maybe a case-by-case scenario in due course. Thank you.
Thank you very much, Victoria. I would like to stop there. I know in the interest of time, we have a lot more questions being put on the chat box. We'll make sure to compile all these questions. We'll put them in a document and we'll try and provide the responses to them. Thank you, everybody. Thank you very much, everybody. Ben, over to you.
Thank you very much indeed, Hassan, for that. So we just got a couple more things to communicate. So Hassan went through a lot of the questions, and as he mentioned, we will be working on those questions that maybe weren't answered, and they will be submitted to the Global Thematic Working Group for Nutrition Information Systems. And also, if there's any, like Victoria mentioned, any additional questions or issues that come up in relation to this or any other nutrition and emergency issue, please do head over to the Global Nutrition Cluster website and submit your query there. And it's worth mentioning that there is also ENNET, the Emergency Nutrition Network Forum, and in there are specific COVID and specific nutrition information forums. So before we finish, Alexa, next slide, please. I want to bring your attention to the rest of the COVID and nutrition webinar series. So we have 3 different webinars that we are putting on or have put on already. The nutrition information one that we have delivered today in English. We also, the child wasting programming in response and preparation to the COVID pandemic, experiences from the field. That was first delivered in English on the 9th of April, and the recording is available online now as well. Next slide, please, Alexa. And there was also an IYCF focused webinar in the COVID pandemic, predicting, promoting and supporting IYCF during the COVID pandemic, reflections and recommendations. And these 3 webinars are also have either or are going to be delivered in French, Spanish and Arabic. So please head over to the TechRRT website if any of those interest you, and please do pass them on to any of your colleagues who might speak those particular languages. Next slide, please, Alexa. So I just want to say thank you very much to everyone for joining the call today. We had well over 200 people on, and so thank you to you and to your those who submitted questions, and a big thanks to the presenters as well for taking the time out of their busy schedules to develop the presentations and share them with us today. And as I have mentioned a couple of times already, please do fill out the webinar evaluation. It will take you a few minutes only. You'll find that again in the chat box. And if you have any questions for any of the presenters, the TechRRT or any of the presenters, then please contact the TechRRT on the email address showing on the slide there. And we will be sure to point you in the right direction. If you need Mathieu or Lucy or Louise or Hassan or Victoria or Mathieu, then we will be sure to pass your questions on and put you in touch. So with that, thank you all for taking part and wish you a good morning, good afternoon, or good night.